All right, I think we're going to get started tonight. Welcome to all of you who are joining our symposium tonight, the Vision of Progress, Advancement in Uveal Melanoma Care and Research. My name is Deb Gerard, and I'm the Executive Director from Impact Melanoma. Impact Melanoma is a nonprofit organization that's been around for over 20 years. We provide early detection, prevention, education, and support services for melanoma patients and their families. As part of the work that we do twice a year, we'd like to reach out to the melanoma community and provide a symposium of topics that we think are really important for people to hear. Our 2023 topics, our first one of the season is uveal melanoma. We'll follow this up in the fall with a program on mucosal melanoma. In addition to this work, Impact Melanoma is the frontier for providing sunscreen dispensers and free sunscreen to communities across the country. We use this as both a teaching tool and a marketing opportunity for organizations to support the sun protection needs of the communities that they live in. So we currently have over 6,500 sunscreen dispensers across the country, and we love working with organizations for bringing both dispensers and programs to their communities. So you can check us out at impactmelanoma.org. I'd like to transition now to our program for tonight. What we're going to do is I'm going to introduce our first two speakers, and they'll do their presentations, and that will be followed with some additional presentation from both our caregiver and uveal melanoma patient. So I'd like to start with Dr. William Harbour. Dr. Harbour is a pioneering retinal specialist, ocular oncologist in cancer research, whose discoveries have transformed the management of patients with uveal melanoma and other eye cancers. He attended Johns Hopkins for medical school, the Wills Eye Hospital for residency, Bascom Palmer Eye Institute for retinal fellowship, University of California, San Francisco for ocular oncology fellowship, and Washington University in St. Louis for postdoctoral cancer research training. He was on the faculty of Washington University for 16 years before being recruited to the University of Miami in 2012, and later at the Sweetser Comprehensive Cancer Center. In 2021, Dr. Harbour was recruited to the University of Texas Southwestern Medical Center to become the chair of the Department of Ophthalmology, where he continues his practice, educational activities, and research. His research has been continuously funded for over 20 years by the National Institute of Health, Research to Prevent Blindness, Alcon Research Institute, and numerous other sources. Among his many transformative contributions, Dr. Harbour invented a multi-gene prognostic test for uveal melanoma that has become the standard for care in North America. His discovery that mutations of the BAP1 are the most important cause for metastasis in uveal melanoma, and the SF3B1 mutations are associated with intermediate metastatic risk for this cancer. More recently, he found the LAG3 is a predominant immune checkpoint molecule in uveal melanoma, leading to new clinical trials for metastatic uveal melanoma. I would also at this point like to introduce our second speaker, Dr. Carvajal. Dr. Richard Carvajal is the Roy James and Tara Zuckerberg Professor of Medical Oncology and Deputy Physician-in-Chief and Director of HEMONC at Northwell Health Cancer Center. He is recognized as a leader within the melanoma field with particular expertise in rare melanoma subtypes such as uveal, mucosal, and acral melanoma. His research has been supported by the National Cancer Institute, the Food and Drug Administration, the Conquer Cancer Foundation, the Melanoma Research Alliance, the Melanoma Research Foundation. He has authored and co-authored more than 250 peer-reviewed manuscripts, books, and book chapters. So I think you can tell from these biographies that we have some of our leading uveal and melanoma specialists across the country. Dr. Harbour was going to begin, and he is going to provide a talk on research leads to reasons for hope in uveal melanoma. So without any more pause, welcome, Dr. Harbour, and we're so thrilled to have you with us tonight.
Thank you again for the opportunity to be here with you tonight. And it's interesting, I was asked to give a talk to a group similar to this a few months ago, and I was asked to, instead of just giving the regular scientific talk by itself, to try to put this into a larger historical context to provide hope for patients, because sometimes we can get frustrated with the seeming lack of progress from day to day and week to week and month to month in this very challenging cancer called uveal melanoma. But I thought that was a brilliant request, and I've really continued to modify this talk and to use it for settings like this, because I think it is important to see just what tremendous progress has been made, and it's accelerating in recent months and years. So without further ado, I'll just, here are my disclosures. Just to be clear, we're talking about uveal melanoma, which is a subset of ocular melanoma. Uveal melanoma involves the iris, ciliary body, or choroid, or any combination of those. It's very different than conjunctival melanoma, which is a different type of ocular melanoma that I will not be discussing tonight. Uveal melanoma is the most common primary eye cancer in adults. It can really occur at any age, but the median age, or about half the patients, are going to be below 60 and about half are going to be above 60 years old. The incidence is, as you see here, about 1,700 per year. But for those that are clearly have melanoma, uveal melanoma, there are many more that have suspicious nevi or smaller tumors that might be melanoma, and we're not sure. So I'll touch on that a little bit towards the end of the talk. So I just wanted to start with the earliest documentation I could find of uveal melanoma in the literature, and this came from 1883. And at that time, it wasn't even clear that they were melanomas. They were called sarcomas sometimes, or melanosarcomas. It wasn't even clear what they were, and it was very uncommon for them to be diagnosed, except at the very end stage when an eye had gone blind or I had already metastasized. This is really a black box, and there's really no treatment at this time except just to remove the eye. It's interesting that this long ago, this entity was known, but very little was known about it. By 1931, more and more research had been done in uveal melanoma. By this time, it was clearly recognized that this cancer tends to metastasize at a high rate. But it was also starting to be recognized that not all of them metastasize at a high rate. Some of them seem to some patients seem to do better than other patients. And doctors and scientists were trying to figure out what were the differences between those that did well and those that didn't do well. So a very famous study in 1931 was this one here, where Dr. Callender noticed that when you look under the microscope at these tumors, and of course at this time all of these patients would have undergone enucleation or removal of the eye. There was really no other treatment option. So the pathologist would look at the tumor under the microscope. And Dr. Callender noticed that there seemed to be two basic different shapes to the cancer cells. And he called the ones on the left spindle cells, and the ones on the right he called epithelioid, meaning that they look like epithelial cells, like the cells on your skin or in your GI tract, but they weren't truly epithelial cells, so they're epithelioid cells. But the fact was that most tumors were kind of a mixture. These are the two opposite extremes, but most tumors had some mixture of both cells. But it was really the first insight that yes, some of these uveal melanomas metastasize at different rate than others, and we might be able to actually figure out which ones are at high rate of metastasis and which ones are at a low rate of metastasis. And then really the first evidence of a molecular approach that I could find was this study from 1941. Molecular meaning they're not just looking at the cells and the shape of the cells and what they look like, but they're actually trying to look at molecules like protein, DNA, RNA, other biomolecules. In this case, they looked at a protein called reticulin, and they tried to associate how much reticulin was in the tumor with the prognosis. It ended up this didn't work very well, but it was really the first attempt to look deeper into the biology of uveal melanoma to determine why some of them metastasize more than others. Then we move all the way up to 1978, and this was a really important paper in the field. It was ended up being called the Zimmerman hypothesis, and we're still trying to figure out why some of these uveal melanomas metastasize and some don't. And again, at this time, all of them were being enucleated. And Dr. Zimmerman was a pathologist at the American Armed Forces Institute of Pathology, and he would receive hundreds or thousands of these eyes every year to evaluate. And what he noticed is that within a couple of years after enucleation, that there seemed to be a rise in the number of patients developing metastasis. And he said, well, I think it's just the mechanical that, you know, when you're do the surgery and you're squeezing on the eye and you're trying to do that surgery, you're actually squeezing melanoma cells into the bloodstream. It has nothing to do with the biology or different cell types necessarily. It's just that you're mechanically squeezing the cells. And so I made a little cartoon to illustrate this, that, you know, somehow you're just physically squeezing the cells into the bloodstream and they end up in the liver. This hypothesis ended up being disproven, but it was a circuitous route to get there. And part of that route involved the development of plaque brachytherapy. We now have different types of radiotherapy. Plaque brachytherapy is still the most common for uveal melanoma, but there were other types that we're using now: proton beam, CyberKnife, etc. But this started with brachytherapy. Brachytherapy means short radiotherapy, meaning the radiotherapy is going over a very short distance. In the case of plaque therapy, we're placing a plaque directly on the eye to kill the tumor. Now, I'm showing you this picture here, and I'm assuming some of you will recognize that this is a very famous movie from the 1970s, I believe, Chariots of Fire. If you haven't seen it, it's a terrific movie. You should see it. But what's important here is that one of the protagonists, not this guy here, not the one on their shoulders, but the one who's holding him up, ended up being a person called Henry Stallard, Dr. Henry Stallard. He was actually the first person to do brachytherapy for uveal melanoma, as well as for other eye tumors. He was in London, and he developed this technique back in the 40s and 50s. And it was really this pioneering work that eventually led to people saying, well, if Dr. Zimmerman's right and we're squeezing melanoma cells into the bloodstream, then maybe we should start doing this radioactive plaque procedure instead. And so that led to a very important study called the Collaborative Ocular Melanoma Study that was going on when I was a medical student. And it went on for almost 20 years and involved several thousand patients in the United States. And in one arm of that study, they compared enucleation to plaque brachytherapy. And they wanted to know, are the outcomes different if patients develop metastasis more if they get enucleation, or do they develop metastasis more with plaque brachytherapy? And it turns out that there is no difference in the survival between patients that get enucleated and who get plaque brachytherapy. And this has been validated over and over through the years, and even other types of treatment. This is true also for proton beam, for other types of treatment that people have tried. So it seems that that by the end of the 20th century, we had realized that metastasis is probably not a mechanical process. And, a corollary to that is there was a widely held belief, and still among some, that you should not biopsy a tumor because that will cause it to spread. But that is also this kind of mechanical hypothesis that you don't want to disturb it or touch it or squeeze it or anything like that. But that's by the end of the 20th century, it's becoming kind of clear that it's more complicated than that. We realized that plaque radiotherapy is just as safe in the appropriate patient. Enucleation is still the appropriate therapy in certain patients with large tumors and other factors. But, based on the COMS study, the vast majority of patients are now getting plaque radiotherapy or some form of radiotherapy. And then importantly, again, metastasis is not merely a mechanical process. We don't really know exactly why, but we know it's not just a simple mechanical process. So it intensified the interest in looking at factors that may predict metastasis, such as bigger tumor size, the location of the tumor, pathologic features, et cetera. And as I had mentioned, at the end of the 20th century, when I'm coming out of my training, most places did not do any type of tumor biopsy for uveal melanoma. It wasn't really taught, and some people thought it was dangerous. There was no effective treatment for metastatic disease. People had tried all kinds of chemotherapy, and there's really nothing effective. Generally, people didn't get very much surveillance because there was really nothing you could do for them. So when I was in training, the doctor might say, go get some blood tests to look at your liver function and maybe get a chest x-ray, but really there's not much we could do. So it's really a very nihilistic attitude. And there was absolutely no industry interest in uveal melanoma. No pharmaceutical company had any interest at all. It was a rare disease, hard to treat. And so there's really no interest. Also, toward the end of the 20th century, we're starting to get a little breakthrough in our understanding of the biology of uveal melanoma. We started to have methods for looking at chromosomes within each cell of a tumor. And the early methods are called karyotyping, which you see here. And this was the first paper that I'm aware of where it was noticed that monosomy 3, which is where you lose one copy of chromosome 3, it occurs at some frequency in uveal melanoma. And they went on to show that monosomy 3 seemed to be correlated with the higher risk tumors, the ones that tend to metastasize. AQ gain also seemed to be associated with higher risk. Around the same time, people were doing mathematical modeling and saying, you know what, Dr. Zimmerman was saying that, you squeeze the tumor and then within a year or two it metastasizes. But when we look back at a large number of patients over time, and we look at patients that had different size tumors, and we calculate how fast they were growing over time, these tumors were not metastasizing last year. The tumors that we find metastasis in the liver or elsewhere, they actually got out of the eye probably 4, 5, 6 years ago. And it just took time before we could find them in the liver or elsewhere. So this concept is now an established concept that we all I believe, to be true in one form or another. But the metastasis or the micrometastasis that we can't find by CAT scan or MRI, that probably occurred several years, 3, 4, 5, 6, even more years, 10 years before metastasis is actually detected in the body, but it lays dormant for some period of time. And so in that case, where they have micrometastasis, we go ahead and treat them with plaque radiotherapy or what have you. Well, they seem to be doing well for some number of years, but then later, despite successfully treating the eye tumor and getting rid of it, they develop metastatic disease. So this is the current understanding of uveal melanoma. It's not that we're squeezing the tumor or the biopsy disrupted it and spread the tumor. There's something intrinsically about the tumor that some of them are spread early, and not only that, but the ones that are successfully metastasizing are able to set up shop in the liver or elsewhere in the body, whereas the ones that don't successfully metastasize, they don't do so well when they get into the bloodstream. So it's not just getting into the bloodstream that makes the more aggressive ones aggressive, is that they have some kind of biological change in them that allows them to survive in the bloodstream, to hide out in the liver or elsewhere, and to recover at some future date, years down the road, and to grow out. And then other ones don't. So it's just a lot more complicated than we're squeezing on it and making them spread. So in the early 2000s, that's when my laboratory started getting interested in uveal melanoma. And we found that you could go beyond just looking at chromosomes and saying whether a chromosome was present or not, but you could look at thousands of genes at one time, and you could look at the activity of these genes and a tumor. And some genes will be not active at all. Some genes will get overactive, and some genes will get underactive in a particular setting, in a particular disease setting. And we found that in uveal melanoma, there were two very distinct patterns of genes that are either going up or going down to form a profile or a signature or a pattern. And so what we found were two basic patterns, a class 1 pattern and a class 2 pattern. And these ended up correlating very strongly with whether the tumor was going to metastasize or not. Those with class 1 tumors had a very low risk. Those with class 2 tumors had a very high risk. We were able to go on and not just look at thousands of genes and their activity, but to find specific genes that become damaged or mutated that lead to these changes in the gene expression profile. The most important of these is in a gene called BAP1. It's really inactivation or damage or destruction of this gene that leads to the class 2 tumor profile. And then there are other genes that we and others have discovered. SF3B1 is associated with an elevated but intermediate risk of metastasis compared to BAP1. And there's really now, we now have a fairly complete picture of the early genetic changes that occur in uveal melanoma, all the way from the normal cell that they derive from. These different gene mutations occur, then you get these gene expression patterns. And then a further change that we recently described was if this gene called PRAME gets abnormally activated. When you put all this together, you can really predict very accurately the metastatic risk in an individual patient. And it really has to do with the genes, not so much with these other factors about how the surgery was done and things like that. It really, there's an intrinsic ability or lack thereof to metastasize in an individual uveal melanoma. So we now have very, very outstanding molecular prognostic testing. In my center, we use gene expression profiling using the Castle Biosciences platform along with PRAME, and then from the same needle biopsy, we can look at mutations. This uses artificial intelligence and very sophisticated technology to do that. This has been prospectively validated by some of the top ocular oncologists in North America. And this is sort of the standard of care now. But what do we do with this information? We know who's at high risk, who's at low risk. Well, first of all, we can adjust people's surveillance. If somebody's at high risk, we do want to do surveillance more frequently, maybe with MRIs of the liver periodically. Somebody's at low risk, maybe we only do that testing once a year with an ultrasound rather than an MRI, things like that. So we can adjust their surveillance, but we'd really like to have treatment. So somebody's at high risk, they can have treatment. The problem is there hasn't been any effective treatment for metastatic uveal melanoma. So I'm not going to steal Dr. Carvajal's thunder, but I will say that there has now been the first drug ever to be FDA approved for uveal melanoma, and that is this drug called tebentafusp or Kemtrack. And patients who got this drug who had metastatic disease had better survival. And the point I want to make here is that this is the first proof that any drug could be effective at reducing metastasis in uveal melanoma, in particular immunotherapy. Uveal melanoma is thought to be an immunologic cold tumor that could not respond to immunotherapy. This has proven that wrong, and has catalyzed all kinds of industry interest in uveal melanoma, which is really good for patients because that's where the money is. The pharmaceutical companies have the money to invest in new drugs. And so they are interested now, and this is a huge benefit for us. There are other targets. I mentioned PRAME. It's a very important target in uveal melanoma that drives metastasis. And there are a number of companies, including the same company that makes tebentafusp, that are developing drugs that target PRAME. So this is an exciting area of interest too. And as was mentioned in my introduction, we found that there's a particular checkpoint molecule called LAG3, and there may be others that are particularly targetable in uveal melanoma. We started a clinical trial in Miami before I moved to Dallas that recently completed enrollment looking at a LAG3 inhibitor in metastatic uveal melanoma. And finally, we're looking at well-tolerated oral drugs like HDAC inhibitors such as quasinostat, which we discovered also when I was in Miami, and a clinical trial is about to be started there for high-risk patients. Quasinostat seems to reverse some of the effects of losing BAP1. So finally, in wrapping up, I'm sure all of you have heard in the media and elsewhere about liquid biopsy in uveal melanoma. And liquid biopsy for our purposes could be some type of ocular fluid, like the aqueous watery fluid in the front of the eye, or maybe the vitreous in the back of the eye, or possibly blood. And just very quickly, I will just say that none of this is ready for routine use in patients, but we are making rapid progress in the research laboratory. There seem to be biomarkers that we can access just from the watery aqueous part of the front of the eye they can't replace tumor biopsy, which I just described, but they can help us know which patients might be at higher risk and need a tumor biopsy. And with circulating tumor DNA, Dr. Carvajal will probably speak more about this, but we can look for little fragments of DNA that have been shed into the bloodstream by the tumor, and we can identify this and quantitate it and look for it to go away with treatment as a predictor that treatment is going to work. And there may be other ways that we can use ctDNA. So in summary, improvement in survival is going to require continued research. We now have accurate methods of prognostication. We're going to need to be able to treat people earlier that have a high-risk tumor, and new approaches to therapy where we intervene earlier as we find more drugs that have activity against uveal melanoma to start a therapy earlier. Really importantly, I can't emphasize enough, for the first time, industry, pharmaceutical companies have an interest in uveal melanoma, and it's going to help us to rapidly make progress in this field. We now have very good tumor biopsy testing, which I just described to you. Liquid biopsy is not going to replace tumor biopsy, but will play important roles in other settings. And finally, I hope that I've convinced you that research is leading to new hope in uveal melanoma. Thank you.
Thank you so much, Dr. Harbour. I think that you are absolutely right, that it's the perspective and the history that leads also to hope for patients and really beginning to understand the long, difficult process to getting to the point that you are now. So thank you so much. We really appreciate your work. We're going to be moving on now. Dr. Carvajal is going to be talking about harnessing the immune system in the treatment of uveal melanomas. So thank you again, Dr. Carvajal, and we're excited to hear what you have to present.
Yeah, Deb, I'd like to thank you and Impact Melanoma and hosting this and just bringing attention to this rare disease, and also for doing mucosal melanoma later on.
I'll be calling you.
Yeah, and why is it so important? It's because these rare subtypes of melanomas have just been harder to treat, and there's just been, until recently, less attention paid.
Exactly.
So it's always really hard to follow Dr. Harbour. So let me see what I can do. But what I wanted to spend time talking about is how we think about using immunotherapy for the treatment of uveal melanoma. And you just heard a fantastic historical kind of perspective of how the field has evolved for uveal melanoma. But if you take a step back and look at cancer in general and how we treat it, you know, there have been various phases over time where we've focused on surgical management and then radiation therapy, chemotherapy, targeted therapy. And certainly now I would say we are well in the era of immunotherapy for cancers. And so the question is, how can we get this to work for immunotherapy? So here are my disclosures. This I think maybe highlights a little bit of what Dr. Harbour was saying about how the recent progresses that have been made in this disease have come from research. And so this is a slide I made some time ago where I just kind of searched to see how many publications are there in the scientific literature focus on uveal melanoma. And you can see in the 80s, we're talking about single digits, you know, maybe in the 90s, we're talking about the dozens. And finally in 2020, we're talking about 300, 400 publications a year. That number pales in comparison to what we do for cutaneous melanoma or certainly breast cancer. And this knowledge certainly has led to improved outcomes. When you look at what's happened in cutaneous melanoma, there's been really rapid progression in how we're able to treat and now cure patients with cutaneous melanoma. This slide is not meant to say that, you know, wow, we're finished with cutaneous melanoma, we're done, but it just goes to highlight the progress that's been made. I tend to not like to talk about survival at these things because the numbers are never where I want them to be. But if you do, and here I will do it for skin, where even as recently as 2000, the percentage of patients with metastatic cutaneous melanoma who are alive 5 years after with the treatments we had were 5–10%. And then you fast forward to now, with the advent of immunotherapies like ipilimumab, the anti-PD-1 antibodies, combination immunotherapy, with the advances in targeted therapy, BRAF/MEK therapy. Now, the median survival for patients with cutaneous melanoma is now around 6 years. And when I see a patient with cutaneous melanoma, even if it's spread to the lungs, brain, liver, the goal is still cure. We're able to cure about half of the patients that we see. That's a far cry from where we were in 2020. And so the question is, how do those therapies apply to uveal melanoma? And what we found is that the same therapies that seem to work very well in cutaneous melanoma only very rarely work in uveal melanoma. So the likelihood of major tumor shrinkage in cutaneous melanoma with a drug like pembrolizumab or nivolumab, the anti-PD-1 antibodies, can be on the range of 40–45%, which is really high. When we look at uveal melanoma, the likelihood of shrinkage is on the order of 5%. And why is that? These tumors are biologically different. Cutaneous melanoma, skin melanomas, form because of chronic, well, early and sometimes chronic exposure to UV radiation, which leads to a lot of mutations in the DNA, a lot of abnormalities. And in part, those abnormalities allow the immune system to recognize and kill off the cancer. On the other hand, if you look at uveal melanoma, this is not driven by UV radiation, has very few mutations in the DNA, and in part, that leads to the reduced ability for the immune system to recognize and kill off the cancer. Now, sometimes it works. This is a patient with metastatic disease, 76-year-old with metastasis in the liver, as you can see here, a small lesion in the lung, a small lesion here in the bone. And this patient was treated with a single agent PD-1. And you can see that after about 10 months of therapy, the liver lesion almost completely goes away. The lung lesion disappears. The bone lesion sclerosis, this is a good response, maybe a little bit of change here. And what was different in this case is this patient had a mutation that actually, instead of having very few mutations in the uveal melanoma, this one had a lot. And that increased number of mutations led to this fantastic response. Sometimes we do combination immunotherapy, the combination of a drug called ipilimumab, which is an anti-CTLA-4 antibody, with nivolumab, an anti-PD-1 antibody. In skin melanoma, if we do this, we can get shrinkage in 55–60% of patients that we treat. In uveal melanoma, it's, at best, maybe 15–18%. But sometimes it works. This is a patient with metastatic disease. And I've shown this slide a few times, but it's so striking, who had all these white spots or spots of metastatic uveal melanoma in the soft tissue, lungs, and the liver. And this patient got a little bit of ipi-nivo. And you can see that there was a significant improvement in those spots. And then with no further therapy, these remaining abnormalities disappeared. And this is a patient who, after finishing the course of ipi-nivo, I was able to just watch for a few years, and the patient did great. It did ultimately come, but this was a really, really great response. And I'll come back to kind of why might that have happened. There are a lot of different types of immunotherapy. Those prior examples that I showed were using these immunologic checkpoint blockade agents, right? And these are commonly used for lots of cancers: lung cancer, bladder cancer, head and neck cancers. But another type of immunotherapy is called cellular therapy. And one example of that is something called TILs, or adoptive T-cell therapy. And this is a type of therapy where we can go in to a patient with metastasis, for instance, a liver metastasis, do surgery to remove a piece of tumor. And then we extract the immune cells, the T cells that were at least smart enough to get into that tumor, even if they weren't able to kill the tumor. And those T cells, we can make a lot of them. We just grow them in the laboratory. And then when we have a lot of them, we just reinfuse them in the patient. And that greater number of T cells, sometimes we modify them, but that greater number of immune cells, when we reinfuse them, can lead to tumor responses. And this is a study that was done at the National Cancer Institute, where they treated 20 patients with metastatic uveal melanoma with this sort of cellular therapy, this TILS therapy. And you can see that 35% of the patients had some degree of tumor shrinkage. And so this was pretty striking. They were actually able to make these cells in the majority of the patients. But importantly, this sort of therapy is a little bit complicated. In this study, 22% of the patients who had tumor extracted ultimately could not undergo the treatment for various reasons. Why do we bring this up? Because there's a company called Iovance that is making a commercial TIL product that we're hoping will be approved later on this year for melanoma, for cutaneous melanoma. The question is, will that work in uveal melanoma? There's a study going on by one of my colleagues, Dr. Shastari at Memorial, doing a small pilot to look at that. There's a lot of work looking at making those TILs better, those cells better, or making them faster. And some of this work is being done at MD Anderson. And they also have a small series that they just presented at our big cancer meeting, where 2 of 9 patients, so 22% in this case, achieved major tumor shrinkage that lasted for a while, 22 months in one case and 16 months in the other. Again, these unfortunately were not cures, but did lead to some patient benefit. The big success that Dr. Harbour talked about was this tebentafusp drug, which is another form of immunotherapy. And this is as he mentioned, it's the first drug to really that we were really able to prove improves outcomes and survival in a meaningful way in patients with this disease. So this is a practice-changing drug development program. This was approved in January 2022, the first drug ever approved, and this is now available worldwide. But what is this drug? I say it is a different type of immunotherapy. And so how does it function? You know, basically, the drug is kind of shown here. And one end binds very tightly to this protein called GP100 when it's expressed by this HLA molecule on the cancer cell. And basically, that just makes the drug itself bind very tightly to the uveal melanoma cells. And on the other side, it just kind of sucks in any immune cells that are in the area. So it brings the immune cell into proximity to the tumor cell, and that by itself is enough to kill the cancer cell. Some of the folks on the call may have gotten this. It's certainly associated with some side effects. And what we tend to see are side effects affecting the skin. So itching, rash, burning of the skin. And we also see effects, systemic effects, something that we call cytokine release syndrome, which is caused by an overactivation of the immune system. And patients can get fevers and chills and drops in the blood pressure. These symptoms are worse in the beginning, and they tend to fade away. And that's what this is kind of showing you in the beginning, weeks 1, 2, 3. A lot of people are getting those side effects, but by week 8, it's much less. And importantly, this drug is administered as an inpatient basically for the first 3 weeks, and then can usually be done as an outpatient afterwards. So on one of these trials, we did that liquid biopsy type work that Dr. Harbour was talking about. We took blood before we started treatment and found fragments of these circulating tumor DNA, fragments of DNA from the tumor cells. And then we checked it again over time. And so we were able to detect the circulating tumor DNA in the majority of the patients that we put on the trial. And what was really striking is that by week 9, the majority of the patients, so 71% of the patients that we were testing, had a decrease in the ctDNA levels. 13% of the patients had complete disappearance of that circulating tumor DNA, which we had hoped that would predict a good thing, right? That maybe that means that there's less cancer there. What was interesting was that the changes in the circulating tumor DNA levels didn't really correlate all the time with the way the scans looked. And so in some patients who had tumor shrinkage, we did see eradication or disappearance of that circulating tumor DNA. But in 3 patients who had tumor growth on the scans, the cancer got bigger on the scans, they also had no circulating tumor DNA found by week 9 of therapy. And then, if you look at how those patients did, those patients did well regardless of how the scans looked, right? So the circulating tumor DNA predicted outcome better than the scans did for this treatment, which is very interesting. We still have to do more work to figure out how to use that circulating tumor DNA, but I think it's really important. So here's that Ipi-Nivo case I showed you before. And what was interesting here was, and remember, this patient was treated with ipilimumab and nivolumab here, and that had complete disappearance of the tumor. But if you look at this patient, she actually had ipilimumab before, and the cancer grew. And she had pembrolizumab, one of the PD-1 antibodies, and the cancer grew. And then we treated her with this tebentafusp drug for a while, and the cancer grew. And then treated her again with the same drugs, basically, that she had before that didn't work. And then it worked again. And so one question here was, well, did the tebentafusp change things to make the immunotherapy, that checkpoint blockade, work better? And so some of the stuff that we did was we did biopsies of the tumor in the liver before treatment and after treatment. And what we showed was that we actually did change the way the immune system was able to function within the tumor with that drug. That is, we drove more of the immune cells into the tumor after treatment than were there before. And, you might hypothesize that maybe that would allow the checkpoint blockade agents to work better. Now, this is a cancer, as I think everyone in the group knows, that likes to go to the liver. And anything that goes to the liver, any cancer that goes to the liver is harder to treat. It just responds less well to therapy. In part, that's because the normal liver is very immunosuppressive by nature. That's how our normal bodies function. But that immunosuppression, the fact that the immune system can't function as well in the liver, also allows the cancers that spread there to grow better. Part of why the liver is so immunosuppressive is these cells, these immune cells, instead of activating, killing things, it actually inhibits the immune response against tumor. And one of those cells are something called myeloid-derived suppressor cells, or these MDSCs. This is the only mouse slide I'm going to show, I promise. But in a series of experiments, it was shown that if you depleted those, if you got rid of those bad immune cells, those MDSCs, which we could do with this drug called ODN-2395, and combine that with immunotherapy, you can completely block the ability of the tumor to grow, compared to if you do immunotherapy alone or that MDSC drug alone. And so this was an animal study, laboratory work that led directly to an ongoing clinical trial where we're putting that medicine to get rid of those bad immune cells into the liver and also treating patients with immunotherapy. And so this is an ongoing trial that's active internationally. And we just reported some early data there looking at, are we actually getting rid of those bad immune cells? And it turns out that we are. And it was also interesting that we looked at those circulating tumor DNA markers, and we're also decreasing that as well. So we're hopeful that these will predict really meaningful benefit for our patients. And so just kind of to conclude and to echo what Dr. Harbour said, I think what we've shown here with the Ventifus story is that the right form of immunotherapy can work in this disease. We do have to address barriers to effective immunotherapy, and I think dealing with that unique liver tumor microenvironment might be important, and that by changing that tumor microenvironment, we might be able to make our therapies work better. And more clinical trials are really needed. And thankfully, this is a little bit of an old slide, but this is as of last September, almost all the ongoing clinical trials for systemic therapies for uveal melanoma. And this list, it's pretty long. I can say when I started doing this in 2004, there were like 5 trials internationally. And this is just a partial list. So, in the future, I think, there will be continued progress. I think there's much more research going on now than before. And, I think with the help of Impact Melanoma and other groups that are really now interested in this disease, we're going to continue to see progress. So I'll leave it at that. Thank you.
Hi, everyone. I'm Kat Alsina. I support the uveal melanoma testing services at Castle Biosciences, and I have the pleasure to introduce our next 2 speakers. We are now going to change gears a little bit and hear from Jill Rosen, who is going to share her son's journey with this diagnosis and the impact that it had on their family.
My name is Jill Rosen. Our son was Jacob William Rosen. The first indication that there was anything wrong was an offhand comment in the car on the way home from school. It was February. Jacob was in the 8th grade. Vision in my left eye is kind of blurry, he said. We had just returned from a week skiing over winter break. He had appeared fine, falling a bit more than usual, but nothing alarming. Jacob had never been significantly ill. He played several sports, was active in community theater and speech team, an overall healthy 14-year-old boy. There was absolutely no reason to think he had a life-threatening illness. The following 2 days after his comment were overwhelming and at times crystal clear. We initially saw his pediatrician, who immediately sent us to an ophthalmologist. She sent us the next day to a specialist at a leading Boston hospital, and then phone call after phone call to different melanoma specialists, as well as eye specialists looking for a different answer, a better answer. And the reality was this: uveal melanoma in a 14-year-old boy's left eye that detached his retina. It was so rare It was difficult to find someone who had treated somebody so young. Fortunately and unfortunately, we did have a relationship with a melanoma oncologist, as I had been in treatment a few years prior. We were also fortunate to live within a 20-mile radius of some of the best healthcare in the country, if not the world. We sought out the best specialists in the field at 4 different hospitals and chose 2 of the 4 to treat him in tandem. The options we were given were few: proton beam radiation that could shrink the tumor but not allow sight in the eye and possibly lead to the spread of the disease, or enucleation, removal of his eye, ensuring that the encapsulated tumor was also removed and that further spread was unlikely. Jacob chose, with our support, enucleation and the placement of a prosthetic. The testing that was done came back as non-aggressive in nature, a hopeful indication that the melanoma would not spread and no other treatment was indicated. Fast forward 10 years. There had been no sign of spread in over a decade. High school, driver's license, winning performances in speech competitions, leading roles in high school, community, and college theater, a bachelor and master's degree, work in professional theater in New York, and a host of family, friends, and loved ones wherever he went. In February of 2022, he started experiencing back pain, which was addressed with exercise and physical therapy. We had no reason to believe that this was anything other than working 10 shows a week. The thought that his melanoma returning was not indicated. He continued working, painting, writing, spending time with friends and family, attending concerts, weddings, and living his life. Tragically, after symptoms increased, difficulty keeping food down, excessive weight loss, and feeling tired all the time, we made the decision to bring him home. He ended up in the emergency room on a Sunday night, June 26th. After multiple tests and scans, it was determined that his uveal melanoma had returned, spreading quickly to major organs, his pancreas and his liver. He was in the hospital for 4 days. We met with his original oncology team, the same from 10 years prior, and the news that they shared was devastating. There is no proven cure for uveal melanoma. His melanoma was also not responsive to the only known drug that was known to help, tibetan. Given his tumors and progression, Jacob was given a 17% chance of survival. His choice was to fight, as was ours. He started radiation while in the hospital, attempting to shrink a tumor in his ileum, his lower back, that was interfering with his bladder and bowel function, as well as a source of significant pain. We then took him home. He then started immunotherapy with Ipi and Nivo. He underwent multiple rounds of radiation, daily trips to the hospital, returning home to wait until the next day and the next round. He had 2 rounds of Ipi and Nivo. He interviewed for a clinical trial in Pittsburgh for a treatment that would utilize his own cancer cells to attempt to provide a cure. Sadly, metastasis was found at the base of his skull, rendering him ineligible for the trial. Radiation was done on his brain to attempt to eradicate the metastasis and enroll him in the study. The TIL treatment outlined in the trial was actively being used in Israel, so we made connections to obtain treatment for him there. In retrospect, we were grasping at straws, anything to give him more time, help him suffer less, and give us more time together. Jacob had met with the palliative care team a few times. It was difficult. It was difficult given his will to live and the stigma in the words palliative care or hospice that represent to him. He was devastated, angry, and in denial all at the same time. We had spent so much energy fighting, there didn't seem to be any left over for anything else. As caretakers, we go into autopilot. Our emotions are left at the door, and planning, cooking, medication management, notating every detail takes over. We kept track of every pill, every ounce of nutrition that he took in, and if he kept it down. Driving to appointments, making sure that every need is met. Talking with experts, doing research, reading about diet options and the latest studies. There was something that had to work to keep our son alive. Saturday morning, August 6th, Jacob was taken to the emergency room with a fever. He was in pain and confused. He had fluid in his lungs and around his heart. Jacob remarked to us, "Don't worry, it's got to get worse before it gets better." There were several procedures to address these issues, which made him a little more comfortable, I believe. These were also his last few days alive. Jacob passed away on August 8th, 2022. He had spent his last few days in the hospital with friends and his family. He died 6 weeks after his re-diagnosis. Uveal melanoma is a rare form of melanoma that doesn't get the attention of other cancers. It is so rare among young people, it's barely a statistic. That being said, it's very real. As skin checks are becoming more regular for young people to prevent the spread of melanoma, eye exams, I believe, should routinely be done to look for retinal tumors. I don't know if routine annual scans would have prevented the death of our son. We've been told that even if they had caught it earlier, there was no indication that any treatment would have been successful. Jacob was a resilient, beautiful, exuberant young man. He was an actor, writer, artist, singer, friend, confidant, brother to Danny, and son of Larry and I. He is greatly missed by so many people.
Jill, thank you so much for sharing your son's story with us. It was a truly beautiful tribute to Jacob, and I'm sure everyone listening is grateful for your willingness to open up and share such a deeply personal experience. Now we are going to hear from Terry Getz, who's going to share her story and experience as a uveal melanoma survivor.
My name is Terry, and my journey with uveal melanoma started about 6 years ago. One day, while I was outside in my yard, I noticed some black spots in my left eye. At first, I thought, those are little bugs flying around. Let me go inside. But it continued, and it never stopped. So I ignored them for a couple of months. But some of my friends told me they might be floaters and I should have it checked out. So I made an appointment with an ophthalmologist, which I found myself nearby, and I had never been to an ophthalmologist before, and I didn't even wear glasses. At my appointment, the doctor told me the black spots were called floaters, and my retina was not detached, so that was the good news. The not so good news was he noticed a freckle. He wanted to do more testing on this. He reassured me that it was likely not serious, and many people have freckles. I scheduled my next appointment in 3 months in his Boston office, where they had more sophisticated equipment. At the next visit, I was told it was still considered a freckle, but probably was nothing serious still. He wanted to see me in another 3 months. On that visit, I was given some pretty bad news. The freckle was no longer a freckle. It was now an active tumor. He wanted me to be seen right away by Dr. Duker at the Tufts New England Medical Center Eye Center. He specializes in uveal melanoma. A week went by and I saw the doctor and he gave me the official diagnosis: cancer. I was so devastated. Nobody wants to hear this news. I had been doing some research on the disease prior to my visit and didn't really have much faith in the outcome. I really thought it was a death sentence. Dr. Duca sent me to a radiology oncologist for a consult. We discussed in great detail what the treatments would be. Since my tumor was small, I opted not to have a biopsy. I was told that I was eligible to either brachytherapy or what's called gamma knife. Both have a great outcome. Gamma knife was offered at the Tufts New England Medical Eye Center and is a radiation procedure only done in a few hospitals in the US, but it's less invasive than brachytherapy. I wish people knew that uveal melanoma is nothing like cutaneous melanoma. When people hear the word melanoma, they immediately think it's a form of skin cancer. And once it's removed, you are cured if it hasn't spread. The truth is, with uveal melanoma, you're never really cured. After my radiation treatment, I was set up with a phone call from the Ocular Melanoma Foundation and was offered a support buddy and groups I could join and find others experiencing the same types of cancer. This has been very helpful to me, but sometimes I needed to take a step back. Not everyone is as lucky as I have been so far, and there is great sadness with others that are battling a not so good prognosis. Some are going through clinical trials, and some have had enucleation. My initial treatment has been the beginning of a lifelong series of testing: abdominal MRIs, chest CAT scans, blood work, which is the standard surveillance. Uveal melanoma is known for spreading to the liver and the lungs, although other organs cannot be ruled out. After having my baseline MRI, a 1 centimeter lesion was discovered on my liver. I would need to have this testing every 3 months. My other option was to have a biopsy of my liver. I chose to watch and wait and continue testing. It's been 6 years now. After numerous local oncology appointments and MRIs and CAT scans, no new growths or new lesions have been discovered. I gradually went from 3 months to 6 months, and now I'm at 9-month intervals. I hope to be at annual testing soon, although surveillance will continue for the rest of my life. Doctors are still not sure what the lesion is, but it does light up on MRI with contrast. So my radiology reports continue to read suspicious metastatic disease. The only way to officially diagnose this lesion is with a liver biopsy. I started seeing Dr. Sato in Philadelphia by way of virtual appointments, but I have opted to not have the liver biopsy at this time. Along with my doctors, we will reevaluate after each MRI and take the appropriate steps. My eye has healed very well with very minimal radiation retinopathy or vision loss, although the tumor is still the same size, it has not shrunk. I was told that it is a white color and that it's dead. So I hope people recognize how important it is to have your eyes dilated and checked. I was lucky to have symptoms. Not everybody has symptoms, and by the time they do, their tumor is too large to, they need to have their eye removed.
We are now going to open things up for a brief Q&A. Thanks to all of our speakers for the wonderful presentations. We are running a little bit behind, so we'll just take a few questions to be respectful of everyone's time. I'll invite our panelists to please rejoin us. If you could turn your cameras back on, that would be great. And to those of you tuning in, if you have questions for our speakers, please go ahead and type them into the Q&A. You should see a Q&A icon at the bottom of your Zoom screen. If we can't get to your question, we will do our very best to follow up with you after the webinar so that no question goes unanswered. And just as a reminder for our audience, please keep in mind that if you have questions specifically about your care or a loved one's care, those questions are best addressed with your doctor. So while we're waiting for questions to come in, we'll kick things off here. Jill and Terry both mentioned that the importance of routine annual eye exams. And I was struck by Terry's comment that she said she was lucky to have had symptoms, which prompted her to get a comprehensive eye exam. But we know not all patients with uveal melanoma will have visual symptoms. So Dr. Harbour, I'm wondering, can you talk to us a little more about what are the most common symptoms and what are the current recommendations in terms of getting routine eye exams? Is it necessary for an ophthalmologist to do that exam, or can that be done by an optometrist?
Yeah, it's a great question. First of all, about half of patients diagnosed with uveal melanoma have no symptoms. That leads to your second question, which I'll get to in a second. But the symptoms to be looking for generally are related to local detachment of the retina by the melanoma, which can lead to flashes and floaters, that sort of thing. Distortion, if the fluid gets near the front of in the middle of the vision, you can see distortion or wavy lines, that sort of thing. What is a common misconception is pain. Pain is actually extremely rare with uveal melanoma. I've had many patients say, "Oh, doctor, I couldn't have cancer in the eye. I don't have any pain." Pain is only when the cancer is very advanced and has caused a lot of problems. It's usually something subtle like flashes, floaters, blurry spot, maybe a kind of a blind spot off to the side. Now, I quickly want to follow that up with most of the time when you have such a symptom, it's not going to be a melanoma, it's going to be something else. So, one should not panic when you have floaters. It's almost always going to be something else, but occasionally it can be a melanoma. Yeah. Second part of your question is, are there kind of routine guidelines about when people should get an eye exam? And unfortunately, there's not. I would say if there's, we all get in our late 30s, early 40s, you get to that stage where you need some help with your reading vision. And I think that's certainly a good time to start seeing as either an optometrist or a comprehensive ophthalmologist for a routine eye exam. Certainly by the age of 40, we should have had at least one eye exam, not just for melanoma, but for glaucoma, for other macular degeneration, but that's usually in older individuals. But the difference between an optometrist and ophthalmologist is that often the optometrist will not dilate the eyes. And most melanomas in the back of the eye, you're not going to see them unless you dilate the pupils, or if you have a special camera, a photograph taken, which can be taken through the undilated pupil. At the optometrist, you'll often be charged for this, like $40 or $50 or something like that. But I think if you're not going to get dilated, it's worth doing as kind of a screening test. Now, how often, if you're 40 and you get your first eye exam and you're totally healthy, the frequency after that, there's really no guidelines, but I would say at least every 4 to 5 years you should have your another eye exam.
Great. Thank you. We have some questions coming in here. So there's a question about chromosome testing, and I wonder, Dr. Harbour, if you can touch on the difference between that type of prognostic testing and maybe gene expression profiling. The specific question is regarding the differences between monosomy 3 and isodysony 3, and is there any difference with regards to disease outcomes?
Yeah, so I'll answer that one first. Monosomy 3 is where you've lost a copy of chromosome 3. You get one copy from mom and one copy from dad, and you lose one copy, and that's called monosomy 3. And the other copy, as we talked about earlier, usually has a damaged copy of BAP1, which is on chromosome 3. So that's why loss of chromosome 3 is important, because it leaves behind a damaged copy of BAP1. So you don't have any copies of BAP1 that are functional. Isodysomy is where you duplicate that damaged copy of chromosome 3. So if you do a monosomy 3 test that's just counting the number of chromosomes, it will count 2 chromosomes and it will say you do not have monosomy 3. But if you use other methods that can tell mom's copy from dad's copy, then you can see there's actually only mom's copy is there. You got 2 copies of it, but it's only mom's copy and both of them are damaged. So that's what isodysomy 3 is. So it's important, not all monosomy 3 tests are the same. Some detect this, some don't detect it. But in general, there's a lot of overlap between class 2 gene expression profile and monosomy 3 or isodysomy 3. but it's not 100%. There's certainly some patients that are discordant between the two. So, you know, and our hands gene expression profiling is a little bit more accurate, but overall, most of the time they're going to be overlap. And in terms of the prognosis is the same between isodosomy 3 and monosomy 3. So I hope that answers the question.
Yeah, thank you. Another question for Dr. Harbour about biopsies. So Terry had mentioned that she did not have a biopsy performed, and I wonder if you could talk a little more about why some patients might not have a biopsy performed and how you might counsel a patient about their prognosis in the absence of molecular testing.
Sure. Well, you know, I have a conversation with every patient, even if I think they really need a biopsy, and it's ultimately their decision. You know, they need to decide. You know, we talk about the risks and the benefits. The risks are low. Like I said, the concern about it spreading the tumor is really, if the biopsy is performed by an experienced surgeon in a careful way, there's really no evidence of spreading the tumor. But you can get some bleeding in the eye. It can rarely cause a retinal detachment or an infection in the eye. These things are rare, but they can happen. So you have to counsel every patient, and they have to decide for themselves. For small tumors, you know, it's less clear how important a biopsy is. If it's very small, they're harder to perform. You know, someone like me who's done thousands of these, I biopsy small tumors all the time. But somebody who only does 10 or 20 of these a year, they're probably not going to feel as comfortable doing a very small tumor. So that would be one factor. But also smaller tumors, even if they are class 2 or monosomy 3, tend to have a better prognosis. So if it's a really small tumor and it's close to the center of vision, your macula, and there's a risk of losing vision, certainly some patients just decide, you know, let's don't do the biopsy.
Thank you. I have a couple more questions here. Dr. Carvajal, Dr. Harbour touched briefly on the importance of screening for metastatic disease following a patient's primary treatment based on whether they're at high or low risk. But I'm wondering, can you talk a little bit more about the types of imaging that are commonly used to monitor for metastasis? Is there consensus about what type of imaging to do and how often to do it? And what do you do at your center?
Yeah, so we finally do have some degree of consensus and guidelines regarding what sort of tests we should do for surveillance in the interval. You know, because this is a disease that likes to affect the liver, we have to image the liver. That is just a mandatory thing if we're going to do the surveillance. And we know that imaging with an MRI is just more sensitive than imaging with a CAT scan or an ultrasound. And so I think for many of us, our practice is to include an MRI of the liver with contrast, with imaging. And because the first site of disease can also be outside of the liver, sometimes it would be the lungs, the lymph nodes, the soft tissue. I also tend to include the chest as well. For the chest, the CAT scans are a little bit better. The downside of the CAT scans is you get ionizing radiation, so there's definitely a trade-off there. It's very rare that something pops up in the pelvis as the first site, or the brain. And so I don't tend to image the pelvis or the brain. So chest imaging with a CAT scan, liver imaging with an MRI with contrast.
Great, thank you. So I have a couple more questions, one for Jill, one for Terry. Jill, you talked about how unbelievably difficult it is to assume the role of a caretaker. I'm wondering if you can provide any advice or, words of wisdom, any little nuggets that you could share for caregivers of newly diagnosed patients.
I think what was important for us, for his dad and I, was really to get as much information as possible and be able to both support your loved one, support your child or whoever it is that you're assisting with, in keeping them as well nourished and all of those pieces about like the holistic person was really important for us, to not make this all about his disease, but just keep him kind of close to us as possible. And at the same time, doing as much research and talking to as many people about what we could do to help him, and support him in his journey.
Wonderful. Yeah. So the power of having information to try and, help you make more informed decisions. Terry, quick question for you. You mentioned that you were able to connect with a uveal melanoma patient support group. What do you feel was the most beneficial part of connecting with other patients? And do you have any advice for patients listening in who are newly diagnosed based on that experience?
Well, I think it's very important to find other people that are experiencing what you're experiencing. You feel less alone. You feel that people understand and that you can hear other stories. And I think initially when you first get diagnosed, your head's in a totally different place than it will be down the road. And if you can support someone and let them know that right now what you're experiencing will get better and that there's hope, and talking to other people that are in the same situation really helps tremendously. So I would suggest always seeking out help and trying to get someone that you can rely on, to trust. And you don't need to tell all of your loved ones every little thing, but people in your group, that's gonna be your go-to. That's gonna get you through.
Yes, and Terry, we talked about that we'll make sure to provide the links here. Maybe afterwards, this webinar will be available on demand, so people can go back and rewatch it, and we'll make sure that viewers have a link to those resources. So I think with that, we're going to wrap up. Thank you so much to our speakers, and particularly to Jill and Terry. Thank you for sharing your personal journeys with this difficult diagnosis. I hope our listeners found this to be informative. Again, this will be available on demand, so you can go back and rewatch it, share it with others. I'd like to also thank Deb with Impact Melanoma for the opportunity to sponsor this virtual symposium. And thanks everyone for joining us. Hope you have a nice rest of your evening.
Thanks so much, Kat.
Thank you.
Thank you.
Good evening.
guys.
Good night.